Go ahead, Dr.
Hello, everyone. Welcome. It's a pleasure to be here with you today. I'm Trent Delong. I'm a resident physician at Full Circle Health in Caldwell. Going to be talking about tuberculosis today. I will preface this by saying I'm going to cover both the active TB and latent TB, but it should be duly noted that the majority of what you'll see in outpatient primary care is latent TB. And we'll kind of discuss that a little bit as we go further on. Some objectives here for you, just basically etiology and pathology of active TB, signs and symptoms, the disease presentation and the course, radiological hallmarks of TB, complications, and then we'll discuss treatment regimens as well. Idaho cases by year. This is directly from the Central District Health. Shows 2021, there were 5 cases. 2022, there were 11 cases. And then I thought I actually put that in there, but maybe it didn't save. 2023, there were 15 cases, 5 of which were in Ada County here in the Boise area. And then in 2024, there have been so far 10 cases that have been basically listed within the state of Idaho. As far as pathology, active TB can generate caseous necrosis in the lower lobes of the lung and hilar lymph nodes as well. Fibrosis and calcifications form a Gone complex. You can see caseous necrosis here. I'm not sure if you can see my mouse, but it's in the upper left image. And then the Gone complex as well here, and then here on the bottom image as well. There's a couple of them as well. Reactivation of latent TB, it occurs at the lung apex, and this is largely due to poor lymph drainage and high oxygen tension. If you look to the right of the screen, you can see a pathology slide of caseating granuloma, as well as acid-fast bacilli noted here on AFB staining from a biopsy. Down at the bottom is a gross specimen of a cavitary lesion of the lung, which pretty profound. And these cavitary lesions with caseous necrosis are fairly common in active or recurrent TB. It can become a miliary TB, active TB that is, can become miliary TB, pulmonary or tuberculosis, bronchopneumonia. You can get systemic spread, as we'll see a little bit later. And it is common to involve any tissue in the body. Common sites that we often see with disseminated TB from an active TB cases in the meninges, the cervical lymph nodes, the kidneys, lumbar vertebrae, to name just a few. Signs and symptoms of active TB: chronic cough, non-productive, as we know early in the stage, but does become productive and purulent later in the disease course. We can see night sweats, weight loss, anorexia, fatigue, hemoptysis, pleurisy and clubbing may or may not be present. And then large cavities can cause amorphic breath sounds. It sounds like blowing air over an open jar top. And I've actually heard this on a case when I was a medical student. We saw an active case of TB. And I'll share a little more about that later. You can get pallor and anemia, leukocytosis, and then hyponatremia if there is associated SIADH as well. Active TB, it says TB signs, sorry, typo. Active TB signs and symptoms. Majority of active TB are very sick patients, but there have been some cases documented without overt symptoms. The majority of active TB patients have infection limited to the lungs. An exception is HIV positive patients, immunocompromised, and the young. HIV positive patients with concomitant TB infection often have pulmonary plus extrapulmonary involvement, as we'll see some examples of that later. No symptoms with latent TB, and so that should also be duly noted. As far as transmission, it occurs from infectious persons with active TB, and the sputum will usually stain AFB positive. The degree of positivity correlates with infectivity, and they utilize the Gaffkey scale, which ranges from 1 to 9. And I won't belinger that point any longer. Droplets are aerosolized by coughing, sneezing, speaking, and these tiny little droplets may remain suspended in the air for several hours, long after the person has left the room. And it may reach the terminal air passages when they're inhaled. As many as 3,000 infectious particles are expelled per cough. And the most infectious patients are those with cavitary pulmonary TB or laryngeal TB, which produces sputum with as many as 10 million AFBs per milliliter of sputum. Active tuberculosis symptoms are on a spectrum, essentially from typical respiratory infections that self-resolve to very sick patients. And the Infectious Disease Society also mentions that you can actually have active TB with, though rare, with little or no symptoms at all. Latent TB, obviously, no symptoms, so asymptomatic, and it is not considered communicable either. Reactivation of TB accounts for 80% of active TB cases, and the majority of recurrence happens within 2 years following initial active TB. However, recurrence has been documented decades after primary infection. And then periods of immunosuppression are also lead to susceptibility of reactivation. As far as active pulmonary tuberculosis, it can be asymptomatic, as I shared already. It's very, very unusual, though. Most people are very, very sick. And it's commonly found in children and in immunocompromised patients. It occurs in the middle and the lower lung zones. Most inspired air is distributed to these regions of the lung. And in malnourished and immunocompromised patients, the disease rapidly progresses and disseminates. It causes mediastinal lymphadenopathy and involvement of distant sites as well. As far as the disease course, reactivation occurs from previously controlled latent TB, usually localized to the upper lobes, as we've already shared. Much higher tension in these regions of the lungs, and these zones leads to very positive environment for mycobacterial growth. The extent of parenchymal lung disease varies greatly, from small infiltrates to extensive cavitary disease. And if untreated, 1/3 of the patients will die within weeks to months. Some spontaneously enter remission or enter chronic progressive debilitating disease. And some pulmonary lesions become fibrotic and may later calcify, but cavities persist in other parts of the lungs if it remains untreated. Overall, patients with untreated active TB have a roughly 50% mortality within months to years if it's untreated. So this just highlights the need for adequate treatment of the disease. As far as active TB diagnosis, sputum microscopy and culture is the gold standard. We have to get sputum cultures. The limitation is if you have a patient with Pseudomonas present in the sputum, it will overgrow, preventing cultural growth. This happened on a case when I was a medical student back in the state of Arkansas. And thankfully, we were all masked up with N95s because it was COVID era. And this patient actually came back with Pseudomonas. And so they treated him subsequently with Pseudomonas, for Pseudomonas respiratory infection. And the patient did not improve, did not resolve, and they retested. And eventually, after I think 3 separate testings over the period of like 2.5, 3 weeks, that they continued to collect weekly, essentially came up positive for TB. And thankfully we were not exposed. But it just highlights the need and actually the gold standard for active TB diagnosis to be done with cultures. Infectious Disease Society recommends solid media and liquid media be as well as the culture. And we do this in the lab with a Lowenstein-Jensen, Middlebrook agars. Here is a picture on the right of the screen with a TB growth on Lowenstein-Jensen. TB growth actually takes several weeks. In the solid media and the liquid media takes up to 3 weeks. Sensitivity and testing can take several weeks, only set up once the cultures are positive, and we have the PCR nucleic acid amplification testing and imaging. All of those play a major role in active TB. It should be noted that PPD and IGRA testing have no role in the diagnosis of active TB. Those are solely for latent TB infection testing, as we'll see here momentarily. Additional diagnostic modalities for active tuberculosis include biopsy, which reveals caseating granulomas, and then AFB stain will show acid-fast bacilli, which we saw at the beginning of the lecture. As far as active TB imaging findings, here is some pictures. Here are some pictures of some active TB, diffuse lung involvement, as you can see, with some cavitary lesions here and here and here. And then you can get a Ranke complex, which is a GON complex, which is calcified. Here is a X-ray imaging finding, which is somewhat difficult to see, of a GON complex. And on CT imaging right here, you can see that as well. Active TB, right upper lobe infiltrate. Here on the white arrow, you can see that. And then with the black arrow, you can see an apical cavitation, which has formed in this image on the left. On the right image, we see GON complexes on imaging. And I'm sorry, my little control for Zoom just blocked my image. Okay. So parenchymal right upper lobe lesion with the right arrow, and then hilar adenopathy with the left, with the yellow arrow as well. Additional chest X-ray of a patient with tuberculosis shown here with the right upper curved arrow shows consolidation of intrinsic cavitation, and then clustered nodular opacities are seen in the left upper and right mid-lung zones. With the straight arrows here and here as well. Additional complications of active TB, we have Rasmussen aneurysm and tuberculosis. A mycotic aneurysm is another name for it, and you can see that on the left image here where the arrows are pointing. And I've actually seen this on that patient that I've shared since the beginning of the lecture. Actually had one of these, and it was pretty substantial. Pulmonary arteriogram showing a pulmonary aneurysm. These obviously are at risk of rupture and hemorrhage and can be fatal as well. Disseminated TB is an additional complication, enters the bloodstream, can go to multiple organs. Chest X-ray can show diffuse nodular lesions with appearance of millet seeds, can lead to weeks of fever, adrenal insufficiency. 30% of adults, 40% of children can actually develop meningitis. You can get hypercalcemia, 51% of cases, as is seen in other granulomatous diseases like sarcoidosis, and it's secondary to excessive macrophage activity. You can also lead to, see vitamin D3 intoxication, and this increases calcium intake from the gut and resorption in the kidney, plus increased calcium release from the bone. This is common to see in children and in AIDS patients. Disseminated TB instances of, here's an instance of miliary TB, another complication of active TB. Here is an X-ray on the top left of the screen showing millet seeds on chest X-ray, a CT scan cross-section showing that as well, here as well. Here's a cartoon graphic showing tuberculomas in the brain. You can see the black arrows here, and in the bottom middle image, you can see a coronal MRI section showing bacillar meningitis, enhancing tuberculomas here in this area and here as well. And here is a miliary TB on gross specimen. Now to the bulk of what essentially we see in the primary care setting most often is latent TB. Tuberculosis skin testing, PPD. How do we diagnose tuberculosis in the outpatient or like latent TB setting? Often we use the tuberculin skin testing, TST, PPD are all the names that we've seen. A positive test suggests latent or active infection with TB, but it does not distinguish between the two. Follow-up chest X-ray and clinical exam is indicated if you pop positive with a tuberculin skin test. If a test is performed properly, the PPD has high sensitivity, but specificity is poor compared to blood tests. You measure the induration, not the erythema, and that is done at 48 to 72 hours. It should be noted that a 5 to 10 millimeter induration is usually, but not always, a false positive due to BCG vaccination. And as a side note, BCG vaccines do not prevent TB infection, but they do make the sequelae of meningitis and miliary TB unlikely to develop. If an induration is greater than 10 millimeters, then it's unlikely due to BCG vaccination. And just to underscore again that a false positive can occur with BCG vaccination, but is not always indicative of a BCG vaccination. False negatives can occur as well with the PPD tuberculin skin testing. Chronic disease, malnutrition, severe acute disease, steroid usage, immune suppression with diseases or drugs. With suspicion of anergy, it is recommended that you repeat the test in 1 to 3 weeks to induce an anamnestic response. So as far as diagnostics and interpretation of these tests, to the tuberculin skin test, PPD, a positive greater than 15 millimeter in a healthy person is what we're looking for. So we want to see an induration of 15 millimeters or greater in somebody that has no risk factors. People in high risk groups, we're looking for a 10 millimeter or greater induration. And those high risk groups are examples such as diabetic patients, patients with hematological diseases, healthcare workers, IV drug users, immigrants within the past 5 years from high prevalence country, children under the age of 4 as well. And then at least a 5 millimeter induration for a patient with recent contact with a TB infected individual. People with chest X-ray findings as well from the past, TB infection, and then HIV positive patients and organ transplant, immunocompromised patients like that, essentially, is what we're looking for. Here's a slide, compliments of Dr. Abby Davis from Boise Family Medicine Residency Program, which highlights this risk groups and then the additional testing modalities, which we'll go over here in just a moment. And this is for your clinical review later. Latent TB diagnosis additionally can be diagnosed using the IGRA testing, which is 2 separate different blood tests which detect latent and active TB. Both will give a positive test, but they do not distinguish between between active or latent TB. The positive of this test, of the blood test, is that it's not affected by previous BCG vaccinations. Brand names that you may have heard, QuantiFERON TB Gold test, as well as the T-Spot test. The benefit to the serum, or the blood testing rather, is it eliminates clinical errors in injection methods, and it has a much higher specificity than PPD. You can get false positives with M. bovis, marinum, and Canacea infections, and so that should be looked at as well if patient has co-infectivity with those particular organisms. So here's an overview of the latent TB diagnosis. The skin PPD TST testing, sensitivity 71 to 82%. BCG vaccination can, but not always, lead to false positives. Variability in injection methods by clinical staff has led to decreased accuracy. I have seen some research papers state that BCG vaccination can actually depress the sensitivity to around 60%, and sometimes lower in some studies. It depends on which study you look at. TB quantiferin gold. So this basically measures the interferon gamma concentration. Sensitivity ranges from 81 to 86%. Clinical staff testing error virtually eliminated. It's considered positive if the difference between the interferon gamma concentration to the Zoom thing is covering. I have to move it so that I can see. Sorry about that. Okay, I lost my spot. So considered positive. So the TB quantiferin gold is considered positive if the difference between the IFN gamma concentration to the antigens and the IFN gamma response to the control is greater than or equal to 0.35 IUs. IFN gamma response to the antigen must be 25% greater than the control. And that is actually important to note when testing.
You're not clearing 2 weeks old, Mia.
I'm sorry? I think somebody had their mic on. As far as the T-spot, measures the number of IFN gamma producing cells, or spots, if you will. Its indeterminate results on immunocompromised is less likely than the TB gold. It's harder to get commercially than TB gold, as in fewer labs actually run it. Sensitivity approaches 95%, though. So that is a benefit. Positive results are considered positive if less than 4 sputum-forming units are noted in the control, and greater than 8 sputum-forming units in either of the antigen wells on the testing. Borderline results are basically called if you have 5, 6, or 7 spots. So you need that threshold of 8 in order to get a positive result. It should be noted that any positive result from latent TB testing should be followed with a clinical evaluation and a chest X-ray. Additionally, active TB and negative AFB smear result does not exclude pulmonary TB, and false negatives are common. Similarly, false positives result are sufficiently common that positive AFB smear results do not confirm pulmonary TB, and testing of 3 specimens is considered the normative practice for active TB. I'd like to thank Dr. Davis for this slide and a couple more slides and subsequent slides here. Treatment for latent TB, and this is kind of the heart of what we will utilize in the primary care setting. Isoniazid, the preferred regimen, isoniazid and rifampicin. It's a 3-month course. The frequency is once weekly, and the dosing total is 12 separate doses. And so that is a benefit to the patient compared with subsequent options. Rifampicin, it's a 4-month course. It's a daily dosing. There's 120 total individual doses. And then there's a combination therapy of isoniazid and rifampicin. It's a 3-month course. The frequency is daily, and you end up with a total of 90 total doses. All of this is weight-based in terms of dosing and can be referenced as well. Alternative treatments is an isoniazid. There's a 6-month and a 9-month course. There's daily and twice weekly. And you can see the complication for the patient can actually be very laborsome to be able to keep up with this and have adequate treatment as well. Treatment for latent TB and HIV patients, positive screening test. This indications for this would be a positive screening test for latent TB, no evidence of active TB disease, and no prior history of treatment for active disease or latent TB infection is needed. Close contact with a person with infectious TB, regardless of the screening test result. These are indications to treat in the setting of an HIV patient. And the preferred therapy is isoniazid, 300 milligrams PO daily plus pyridoxine as well. And the duration of therapy is for 9 months. Here's some alternative therapies that you can reference on your own time. So who should get pyridoxine? Patients at risk of neuropathy, pregnant and breastfeeding patients, HIV patients, diabetes patients, alcoholism, malnutrition, chronic renal failure, advanced age. The dosing is 25 to 50 milligrams per day, and it should be noted that patients with existing peripheral neuropathy should have increased pyridoxine dosing to 100 milligrams per day. That is the current recommended guidelines from the experts. So one thing I'd like to highlight is Full Circle Health's a partnership with the Department of Health. We have a TB clinic. Dr. Abby Davis from the program in Boise. She's the program director there, as well as the director of the TB clinic in Boise. And we treat a large population of immigrants here. And we also have an active TB clinic that Dr. Davis heads up. And it's a valuable resource for the family physician association and providers here in the state of Idaho. Feel free to reach out if you have questions or patients. Also, you can reference your local Department of Health, which is a valuable resource if you encounter patients in that setting. And here is a website that you can reference to be able to reach us if you need any other resources as well. Here are my references, and I would like to extend a special thanks to Dr. Abby Davis, the program director for Boise Full Circle Health Family Medicine Residency, as well as she's also, as I mentioned, the director of the TB clinic at Full Circle Health, our program director, associate program director at Full Circle Family Medicine Residency in Caldwell, Dr. Portnier and Dr. Joselle Skinner, and as well as Dr. Mark Stillwell, my professor and one of my mentors, infectious disease chair at my medical school, and also at pardon me, University of Arkansas School of Medical Sciences in Little Rock, Arkansas as well. I'd like to thank you all for your time, and I hope that was very helpful, and I'd like to open it up now. I'll turn this back to Liz to kind of MC.
Thank you, Dr. Delong. That was great, and lots of good information. Just as a reminder, as I shared before, the video recording of this within the next month will be posted to the CME library. So when I send CME certificates around, I'll send the link to that so people can review it there. And we are happy to take any questions in the chat, or if you want to unmute and ask your question, comment, any kind of sharing you have with Dr. Delong, please go ahead.
If there's no questions, I can actually just share a little brief thing about my medical school experience. So I was a fourth-year medical student. It was actually doing rounds at University of Arkansas Medical Center in Little Rock, Arkansas. Happened to be during the COVID era. So we had like 2 entire floors of the hospital dedicated to COVID. We were all masked up in N95s running around. It was crazy. I'm sure we all remember the craziness of that. in that experience, we had a patient that had walked in with little to no symptoms other than a cough. And he's the gentleman that we tested, recurrently over several weeks, and ended up having an active TB case. Initially, there was no presentation on imaging, but subsequently developed. And he ended up having miliary TB later on in the disease course. He was thankfully able to be treated and was discharged. But it just highlights the fact, because this was on the family medicine service, that though active TB is not something that we would typically encounter in the primary care setting, anybody that's involved in inpatient medicine at any time could absolutely encounter this, and it should be on our radar. As I shared, the numbers have increased in times recently here in Idaho, and with COVID, we've had a lot of people move from different states, which are very, very high density of TB cases. And so it should be something that should be on our radar and our differential as we both look at it in the outpatient setting and the inpatient setting. Dr. Portnier, our program director here in Caldwell, recently had a patient who we had to treat for TB because she had an exposure as well from a family member. And so it does need to be on our radar as we think about treating upper respiratory infections.
Any other questions in the chat or any unmutes to ask the question directly? Well, it looks like everybody's still just absorbing the great information you shared, Dr. DeLong. Thank you so much for that important presentation. I just dropped in the chat that our next grand rounds will be on October 14th. It's with the ISU program. Topic and presenter information is to follow. It's at 12:30 p.m. Mountain Time. And then, as I said at the beginning, stay tuned for information on our virtual KSA on Saturday, November 16th, which will be on pain management. Registration will open for that soon. You can expect your CME certificate for this if you fill out the Google form or email me. Don't forget to do that. I'll drop that into the chat again right now. Within the next month, we have a little bit of a slowdown at AAFP on the applications right now. So don't worry, it's coming. It'll be there within the next month. Any other comments from attendees? All right. Anything else you'd like to say, Dr. DeLong?
No, I just want to thank you all for being here today, and just wanted to highlight this important topic. And so thank you for your time and the opportunity to present.
Well, it was wonderful to have you here today. Thanks everybody for attending, and we'll see you again soon.
Thank you. Bye-bye.